I would like to call upon Professor Rohit SAXENA. There's a lot of work on myopia, and he would be speaking on controversies in management of childhood myopia.
Thank you for the opportunity to be here. And we've been hearing such wonderful news. I kind of feel guilty, trying to dampen the celebrations that are almost starting. And I do not have any financial disclosures to declare. And I think after I finish, I don't think I ever will. So we've just seen there is a whole lot of options now available, and it's very exciting that we have a lot of choice that we can give to our patients. We'll try and run through the questions. So we've heard a lot of good news, but behind that wonderful packaging, there is always something lurking dark, So the first question is regarding the effectiveness of management techniques, and we'll run through the various techniques and look at the questions. The next question, it was dealt a little bit about the long-term effect of the Atom 1 and 2 studies, and how it doesn't look so rosy 20 years later. So whether the effect that we talked about can actually sustain itself. What are the potential side effects? Now, at least for atropine, we know they work through some receptors. The receptors are not there for atropine to come and stop myopia progression. They are there for a purpose. So what's going to happen 20 years down the line is something we need to ponder over. So long-term consequences of the interventions we are doing today. There are still absence of standard guidelines for treatment options, and we are still, a lot of this treatment has kind of come about accidentally. So we've realized that it possibly works. So we still don't know the optimal dosing, we still don't know the duration of therapy, and we don't know how long we to continue. And of course, patient compliance is a challenge in many of these. Sometimes we are giving very unrealistic expectations. What works in a trial need not necessarily be the same in real world. So our car statistics look great, but when you come back from Delhi roads, you realize that it's not giving the mileage they promised you. So those are thoughts that you need to take back. Lack of long-term data still of long-term treatments, and of course, again, individualized treatment. Now, how do I identify which is best for which child? Currently, I'm just kind of what I give. So atropine, a lot of work has gone on. It's something we know. Great efficacy, different races, different efficacies. Recently, the Caucasian studies showed, one study showed very good, the other said no good. So we don't know where we are. There is conflicting results among studies and variation in the effects that we get. The next question is statistical significance that we as researchers value and take as God's will, is it really clinically significant? Am I making 0.25 diopters over 1 or 2 years difference every year for the next 10 years, making that huge an impact? So that's the question. Always any therapy should have a clinical significance. And as I mentioned, racial differences. What is the optimal concentration? For every race, there is different pigmentation, there are different choroidal thicknesses, there is different penetration of drugs through the cornea. We know that. So possibly each race, each region has to identify its best possible concentration. So there is a lot of questions we need to answer. Long-term efficacies is 2 to 4 years, irrespective of the age at which I start therapy, enough? Do we continue longer? 10 years, more. A child that starts at 6 years is going to continue progressing till 17 to 18 years. So am I going to continue atropine for another 12 or 14 years? So these are questions that are still answered. And then in that case, if I have to do, what is the long-term efficacy and safety? We are still unsure of why we are developing myopia, what to talk of, how many of our interventions are working. As I mentioned, a lot of this is accidentally our understanding. Potential rebound. So will it come back? Will everything come back irrespective of what I'm going to do? And then finally, a major question. Do I sudden stop or do I taper? There is a lot of thoughts behind taper, but there is no evidence at the moment. So that was a lot of questions on atropine, considering that so much work is going on. I hope we have some more answers. Spectacles. Great. Again, the thought's superb. Now the question is, does peripheral refraction matter? Now we have so many studies on efficacy of these myopic glasses, and they say that peripheral hyperopia is the cause. Now basic thought is then either peripheral hyperopia is in all these children who progress, or else it should be effective only in those who have peripheral hyperopia. Now there's not enough evidence directly that correlates this. So, but that's good news and bad news. Bad news because, our presumptive hypothesis may not be the real one. The good news is that, most studies show that it works good, and irrespective of whether there is or there isn't peripheral hyperopia, and many of these studies don't measure that. So probably it works, but, a hypothesis, is it how true? Difficult to say. Impact on visual quality. When the child is looking to the periphery, how does it affect? There is no standard data to support selection of one lens over the other. We have a lot of choices now. And of course, we have a new technology which is talking about contrast. So how do they measure or match up against one another? There is, of course, always, and true for all interventions, a variation in the response among individuals. So we still don't know. A great talk by Marcus that we could probably get in the future an idea which is best for which guy, but well, till now, we still worried. And in spectacles, the maximum power available is give or take 10 diopters. A little bit more on with astigmatism or without, but that's about our upper limit. So high myopes, we still don't have any treatment. Orthokeratology, again, a wonderful intervention that's been around for long, spectacle free. It's a poor man's refractive surgery. They kind of found out that it's effective in preventing myopia progression. But again, the debate is on long-term effectiveness of orthokeratology, its potential effect on corneal and eye health, and maybe it's not accurately representing the long-term change in myopia because of the fact that it's causing corneal changes, there is epithelial changes which are thickening of the epithelial in the mid-periphery. So our baseline may be changing. So what we are measuring at before the start of ortho-K therapy, are we measuring it at the same baseline or the same back to the same corneal curvature and epithelial thickness? So these are questions that are there, and of course high dropout rate. I mean, it's very difficult to sustain, and while we are giving orthokeratology to our children, it's becoming a challenge to get them to continue. Then of course the constant concern about corneal health, especially in equatorial regions in India, hygiene is always an issue. The cost is of course an issue, while I'm calling it the poor man's refractive surgery, but still on the whole it does cost quite a bit. And then, is the effectiveness sustained after discontinuation? How long does the effect last? And as I mentioned, is it true effect or it's possibly just the structural changes that are seen? Multifocal contact lenses, in fact, were the first ones to get FDA approval. Again, unfortunately, for whatever reason, there are limited studies and no clear guidelines. Of course, information is still coming in, constantly getting generated, so hopefully we'll have more information on that. But there is very little information on good long-term effects of multifocal contact lenses. Now we'll come to environmental modifications, which I personally am very passionate about, and I keep telling and talking to children and parents about this. But then how much outdoor activity is effective? A lot of studies have said that 2 hours a day of outdoor activity is good. The child can be doing anything, can just be walking around, sitting under the tree, just daydreaming, but he should be with his eyes open during daytime. But how much, how long, what is the nature of illumination? Now, in everywhere you have seasons, you have variation in the illumination levels, daytime, early morning, nighttime. Delhi, 2 o'clock in the afternoon, you're just going to fall ill, and I don't know what's going to do to the myopia, but you're not going to last too long. So that would be not my worry for them. So again, then we come to, of course, Pawan is going to talk about outdoor activity and near activity. How much near is acceptable? And today's competitive world, near work cannot be avoided. So which digital devices, tabs, phones, are there a no-no? Again, it's important to remember, myopia is really the youngest lifestyle disease in humans. The genetic profile over the last 40 years in any part of the world has not changed. It's the environment that has changed. So it is an environmental disease, and we must do environmental modifications which should be, individualized. So you can't have one solution that fits all. And then, of course, in a place like India, sun exposure, feasibility of implementations, how can you get spots at 2 o'clock in the afternoon? And of course, associated with that is the vitamins and vitamin D, that is an issue. Light therapy, a wonderful new kid on the block. We hope we'll get more. But again, the concern will always be that what is the long-term effect on the macula? 40 years down the line, are we going to see a far greater incidence of age-related macular degeneration in these patients? We just don't know. These are questions we will learn and know as we go along. Finally, combination therapy, again, great, but we don't know the answers, or we have a lot of questions to individualized therapy. Combination therapy, great for rapid progressors. Who do you define as rapid progressors? how are you going to decide which combination is good? So theoretically, one optical, one pharmacological, great, but choices are immense, and again, individualized therapy. So there are a lot of controversies, not only regarding how and why myopia is developing, but also on the management. And it's very, very important that we have informed discussions with our parents, the children, and the caregivers before we choose a treatment. Thank you for the